I'm going to be giving a bit of an overview. I'm going to be talking about a few different topics, but particularly drilling into the Murray region and talking about what some of the priorities are in the local area. Very minimalist. Great, thanks. Next slide, thanks. So I'd like to begin by echoing the acknowledgement of the traditional owners of the land on which I'm presenting today, and pay my respects to elders past, present and emerging. And this is, of course, particularly important because of the disproportionate burden of hepatitis B and hepatitis C, as well as other liver diseases in the Aboriginal and Torres Strait Islander communities across Australia and First Nations peoples globally. I'd also like to thank our funders, particularly the Australian Government Department of Health, which funds the mapping project. Next slide. So just a bit of an overview of what I'm going to talk about, and I'm aware that some of these topics have been touched on by the previous speakers, but I'll just kind of add some extra components and reinforce some of the information that's been shared around transmission and prevention and the kind of global context. But particularly I want to focus in on the prevalence and distribution of hepatitis B and C, how it's distributed by population, and also what are the priorities according to region, particularly in the Murray area. I'll talk a little bit about what we know around the potential impacts of clinical management on outcomes and some of the patterns there as well, and the priority populations, but also talk about how we've progressed, what the gaps are, and where improvement is particularly needed. And as I've said there, I really welcome questions throughout, so I'll try to leave pauses, but yeah, just stick your hand up, interrupt me whenever you want to check something or go over something that I'm talking about, if you'd like. Next slide, thanks. So yeah, as Kay mentioned, it's sort of important to take a step back and think about viral hepatitis as a sort of a global health problem. And as the data shows, viral hepatitis is a very significant one, and it's one of the leading causes of communicable disease deaths worldwide. And the interesting thing about these comparisons, we talk about comparing to HIV or tuberculosis. The thing with viral hepatitis is that we actually do have effective treatments. We have a cure for hepatitis C, we have management and vaccination for hepatitis B, which we don't have, for HIV, for example. We don't have a cure, we don't have a vaccine. And yet, despite these really effective tools, we still see this really shocking number of deaths. So that's something that really needs to be addressed and is important to sort of keep in our minds, that human burden. And because 90% of those deaths are due to chronic hepatitis B and C, I will be focusing on those topics particularly, but thanks so much to Kay for giving the overview of hepatitis A through E, because it is important to have that sort of overview. And I think often there can be a bit of confusion among people who are affected by viral hepatitis about things like transmission routes, so it's good to address those kind of differences. And just to sort of, again, complete the picture, so over 350 million people are living with chronic hepatitis B or C worldwide. So I know this has already been gone over, so I won't go into detail, but just to touch quickly on some of the key points that are really relevant to my discussions of the epidemiology. So for chronic hepatitis B, it's important to recognise that the most common route of transmission is mother-to-child transmission, and that's true globally. So somewhere upwards of 80 to 90% of people who have hepatitis B acquired it at the time of birth. And the distribution of hepatitis B is largely just related to populations where hepatitis B is more common and has been more common for tens of thousands of years. And when we're talking about strategies to prevent that, vaccination at the time of birth it's so incredibly crucial. And Nafisa will be talking more about that in her presentation. But again, for both hepatitis B and C, there's aspects that are really important: harm reduction, safe injecting, safe healthcare. That's usually something we can rely on in Australia. But of course, there are many places overseas where that's not something that can be relied upon. So very important to be aware of. And again, treatment is available for both conditions, and both are highly effective at reducing the risk of adverse outcomes, which I'll talk about later. And yeah, largely asymptomatic, so needing testing. I would also point people to the national hepatitis B and hepatitis C testing policies, which are generated by ASHM. They're really good resources with lists of all the people who are indicated for testing and really good interpretation of the results. Next slide, thanks. And again, just to go back to that it's a preventable global health problem. So for hepatitis B, there's been amazing progress with vaccination of infants. About 85% of infants born in 2019 received hepatitis B vaccine by 12 months, which is just a really amazing achievement, and something that we shouldn't overlook when we're sort of addressing these problems as issues. This has been a global focus, and it's been really amazing. And there's been an analysis looking at China alone, and estimated that over 30 million infections have been prevented in China alone since the early 90s due to hepatitis B vaccination, which is just an incredible achievement. And that means that just in China, at least 5 million people won't die of liver cancer because of this intervention. So it's just such a powerful thing. But there are still gaps, both in the coverage of infant vaccine, but also for the birth dose, which is really important for preventing mother-to-child transmission. And the uptake of that is only around 45%. So that's something that does need to be addressed. But Nafisa will talk about the coverage of that in Australia, which thankfully is higher than the global level. But if we're talking about those sort of 300 million people who are currently living with hepatitis B, but it's too late for vaccination. That's not something that's going to help, obviously. And so the real key there is getting people into monitoring and to treatment. But unfortunately, at the global level in 2019, only 3% of people receive treatment. And it's estimated that at least 15 to 20% of people need treatment to prevent adverse outcomes at the global level. And similarly for hepatitis C, we have highly effective management strategies, but the coverage is incomplete and it's very patchy according to region. And of course, harm reduction is key. That needs to be continued because obviously people can acquire hepatitis C again after they've been cured. So that's something that's really important also for just holistic healthcare for things like alcohol and other drug therapies. So focusing on Australia, it's estimated that hepatitis B affects over 220,000 Australians. And I'll just mention, so most of the statistics that I'm going to be presenting in this presentation are drawn from the National Viral Hepatitis Mapping Project. And I have a couple of our national reports here, if anyone wants to grab one. It's got all the sort of detailed information. You can look up your area, you can look at data on liver cancer, prevalence, treatment uptake, all sorts of stuff like that. So, and we also have a website which you can go to and you can look at the online portal and sort of drill down into different regions and do comparisons and that kind of thing. So yeah, just let me know if you want any more information about that. But the mapping project allows us to estimate not just how many people are affected and where they are, but the priority populations that are affected. And so this chart shows the distribution of that. And you can see from that that the majority of people living with hepatitis B in Australia were born overseas, most commonly in the Asia Pacific region. So top countries of birth include China, Vietnam, Philippines, those sorts of places. And because of this distribution of priority populations, we see reflected the distribution according to geography. And so you can see from that chart there, so in the metro regions of Sydney and Melbourne, there's much higher prevalence than surrounding areas. And that's related to the migration patterns and the settlement of people born overseas. And because Aboriginal and Torres Strait Islander people are at least 6 times more likely to have hepatitis B, that is also reflected in the higher prevalence that we see in NT and in remote areas of Queensland and WA. And so it's really important for us to be aware of these priority populations when we're tailoring those sorts of interventions. And just another thing I'll mention about the mapping project, I'm really always keen to hear feedback from people who are working in the regions that we're mapping to get your thoughts, whether what we're showing is reflecting your experience and to try to understand the diversity better. So if you've got some feedback on that, again, feel free to contact me. And so this chart presents that sort of distribution by map in a different format. And so this is ranking by primary health network of 31 primary health networks in Australia, those that have the highest proportion of the population living with chronic hepatitis B down to the lowest. And you can see there that, as I mentioned, Sydney, Melbourne, and remote WA and the NT are very much represented in high prevalence areas. And you can see the Murray region is sort of somewhere around the lower part of that, has lower prevalence than the Australian average. But importantly, primary health networks are pretty large, unwieldy sort of measurement units. And so within the region, there's a lot of diversity, and I'll talk a bit about that later. Well, right now. So this map shows that zooming in on Victoria. So you can see, as I mentioned, that higher prevalence in the Melbourne region, but also up along the Murray, Mildura, Swan Hill, and also in Shepparton, there's regions of higher prevalence of hepatitis B compared to surrounding areas, compared to the Victorian average. And that relates to, again, those sort of priority populations. And I mentioned the top countries of birth for Australia overall, but that varies a lot depending on the area. And so in Murray specifically, Italy is a much more common country of birth for chronic hepatitis B than it is in other areas, just based on the population distribution. But again, I can provide more information about that if people are interested. So switching over to hepatitis C now. So obviously the priority populations are largely quite different for hepatitis C, but we also see strong geographical patterns. So it's estimated that hepatitis C affects about 118,000 Australians at the end of 2020. And the priority populations, as I sort of talked about, and as Pearl and Kay have covered, priority populations include people with a history of injecting drug use or who are currently injecting. And also incarceration is a very important risk factor. And obviously those two factors cross over a lot. Many people have a history of both. But there's also an important sort of subgroup who are people born in higher prevalence countries. And I just pulled these data from the notified conditions for Victoria. These are the most top 5 most common overseas countries of birth for high prevalence areas for hepatitis C. So obviously lots of people born in New Zealand, for example, are notified with Hep C, but that's just because we have a lot of New Zealanders in Australia. These are some of the regions that have higher prevalence and are reflected in the Australian population living with hepatitis C and need a different priority response in terms of engagement than potentially, people who are in prison or have a history of imprisonment, that sort of thing. So it just shows that real diversity. But you can see from the map, there's much less clustering of hepatitis C in metropolitan regions. It's much more evenly distributed and much more common in regional and remote Australia than in the cities. And again, so this is the same sort of depiction, but for hepatitis C. And again, you can see the Northern Territory unfortunately has the highest prevalence of hepatitis B and hepatitis C. But you can see here, one of the key differences is that the primary health networks with the highest number of people living with Hep C per head of population, overwhelmingly they're people, they're rural and regional primary health networks. And so that really highlights the importance of these sort of forums because so many people living with Hep C are living outside major cities. And that has, leads to challenges a lot of the time with access to healthcare. And then again, drilling into the regions. So again, you can see that those 3 areas that I sort of highlighted for hepatitis B also have a higher prevalence of hepatitis C. So Mildura, Shep, and that Murray River, Swan Hill kind of area. And obviously these are just geographic sections. So Mildura is one part of that, but it also includes the surrounding areas. So it's sort of more complex than that, but that's how we categorize them. But the prevalence in the Murray area overall is higher than the Victorian average. And as a point of comparison, the prevalence in Murray is about 0.8% compared to Eastern Melbourne, which is about 0.4%. So it's quite a substantial difference and means that prioritising Murray for delivering Hep C care is going to be really important. So we can talk a lot about the number of people who have hepatitis B and hepatitis C, and that's important, but it's really important not to forget that what we're really talking about is people who are living with a constant risk of liver disease and liver cancer if they're not receiving care and treatment. And so this is just highlighting the overall Australian liver cancer trends. So you can see this is a chart from the Australian Institute of Health and Welfare, and they basically rank every cause of cancer based on how much it's decreased or increased since 1982. And you can see there that liver has overwhelmingly the largest increase, nearly 300% since 1982. And that's largely been driven by the increasing prevalence of hepatitis B and hepatitis C and the aging of those populations, leading to adverse outcomes. And we've seen some promising trends of that in the most recent couple of years, and I'll share some of that data. But it's really important to recognise that liver cancer is just such a huge priority. And hepatitis B and hepatitis C are key causes of liver cancer in Australia. Obviously, there are other causes of liver disease, and fatty liver is an important component, but it's important to note that for Victoria, at least, Hep C, alcohol, and Hep B are the 3 most common causes of liver cancer. And fatty liver disease, there's need for better data on that, but we don't yet have a good picture on how much liver cancer is being caused and how the adverse outcomes are kind of playing out. But at the moment, at least, we can see these really clear sort of priorities. And again, of course, we have to map this. So the next slide just shows the distribution of liver cancer incidence according to Primary Health Network. And unsurprisingly, those areas that have a higher prevalence of hepatitis B in particular, because it's so geographically clustered, tend to have higher rates of liver cancer. So those based in Melbourne and Sydney. So we can really see the reflection of, not just epidemiology counting people, we can see the adverse outcomes playing out for people. Just to note though, these are data to the end of 2014, and so it's very likely that these patterns may have changed with those shifts that I mentioned earlier in relation to treatment and care. So yeah, there is some good news, and it's really important, I think, to step back and look at what we've been able to achieve, and then also what still needs to be done. So hepatitis B and C care and treatment, I'm sure Kumar and Joe are going to talk about that much more detail, but the simple message is they both greatly reduce the risk of advanced liver disease and liver cancer at a population level, and that evidence is incredibly strong. And there's already been an impact from both of them in Australia. So you can see here, this is some model data from one of my colleagues, and you can see that at the time, there's a bit of a lag, obviously, because it takes time for these to have an effect. But since the introduction of highly effective antiviral treatments for hepatitis B in Australia, we've seen a decline. And in fact, comparison to what was previously an increase, there's been a decline in the estimated mortality due to hepatitis B in Australia, which has been really promising. But as you can see, over 300 people still lose their lives due to Hep B. And so that's where we need to increase the treatment uptake from the current level to our target levels. And then on the next slide, I have data for hepatitis C, and this is incredibly striking. There's a linked data from the Kirby Institute, an analysis led by Mariam Alavi. And you can see this is just the data for decompensated cirrhosis. There was an incredible increase over the 10-year period of incidence of decompensated cirrhosis, nearly doubling. And then from the introduction of direct-acting antivirals, an incredibly rapid and significant decline. And so it's estimated that the incidence would have kept increasing without the direct-acting antiviral treatments, and instead we've seen this reduction. And these are just data to 2017. It's estimated that by the end of 2020, the number of people who died due to hepatitis C in Australia has decreased by 45%, in contrast to the previous increase. So again, there's still much to be done, but incredibly impactful, and just great to think about the number of people who have had these adverse outcomes prevented and who've been able to live longer lives because of treatment. So it's I find it really, really amazing, and I think it's just an incredible amount of work that's been done by people in Australia to get these drugs listed and to get them out to people in really challenging circumstances. So yeah, I just wanted to sort of highlight that. But again, also important to look at where we're tracking and what can still be done to improve. So just talking a little bit about the progress in treatment for hepatitis C. So I think this was touched on earlier, but we had a very rapid initial increase in treatment uptake as soon as the drugs were listed on the PBS. Over 30,000 people got treatment in the first year, which is just an amazing achievement. But it has been sort of gradually declining year on year since then. And in a global context, Australia is doing amazingly well. And that's partly due to how wide the eligibility criteria, essentially any person in Australia who has access to Medicare can access these drugs, and there's no limitations based on previous or current injecting or those sorts of things, which are a real problem. And actually some data show that that's a common misconception among Australian GPs. They're worried that they can't treat their patients while they're injecting. But obviously, in fact, that's incredibly important, because that means that they are preventing further transmission if they're still sharing equipment with other people. So yeah, it's a really amazing achievement, but it does mean that we're not on track to meet the targets that we set, which was 65% uptake. We're currently at about 50%, probably 55% by the middle of 2022. So there's still work to be done. And the next slide just shows some of the reasons for that. So this describes the cascade of care for hepatitis C. Can I just get the next slide? That's okay. It's not responding. Perfect, thank you. And so this shows the sort of key steps in hepatitis C care. And so it looks at people who've been diagnosed, people who've had that confirmatory RNA test, which Pearl talked about, and which is so important to actually identify whether people have chronic active hepatitis C. And this is showing the sort of trends over time. So the proportion treated is the proportion each year. But you can see there that there's still a substantial number of people who are living with Hep C, but haven't actually been diagnosed. They don't even know that they're antibody positive. And then within those people, there's also a significant proportion who have been diagnosed antibody positive, but have never had a confirmatory PCR test. And so they couldn't possibly be accessing treatment because that sort of follow-up work hasn't been done yet. And so that's a really key gap that needs to be closed if we're going to get people into treatment. And one of the other things for this, it's not just confirming hepatitis C for people who have chronic infection. That means that there are thousands of people who think they have hepatitis C and they actually don't. And that's something that I don't think anyone should have to live with. And so that's a really key reason for making sure that that follow-up testing is done after an antibody positive. And obviously that's something that's quite complicated. It's a challenge often getting people back in, having to draw blood twice. It's inconvenient, that sort of thing. But I think it's really important for that. Oh yeah, next one's good, thanks. And one of the other factors that we are aware of is that treatment uptake is incredibly variable by area. And so you can see there Western Victoria at the top of the chart has actually met the 65% treatment uptake target that was set in our strategies, which is a really, really great to see. And there's strong representation from Victoria in the top treatment uptake regions. And I think that's due to a lot of really amazing work of Victorian clinicians and workers, health workers in so many different settings and peer workers and all that sort of thing. But there's also the factor that the health service access disparities are a little bit less in Victoria than they are, for example, in country WA or Western Queensland, which are incredibly remote areas and have really huge challenges with regard to reaching people. But still worth highlighting, so Murray PHN, which I've circled there, has above average treatment uptake compared to Australia overall, which is really great to see. But again, we don't just stop at the PHN level. It's always important to look at the distribution within that. And again, in the MacLachlan report, you can look this up, you can see all the different areas. And so on the next slide, I've just got the treatment uptake picture for the different regions. And so you can see again, there's in the regional cities in the Murray area, there is lower treatment uptake than average. So that's something that we're aware of and trying to make sure that those areas are prioritised and have the resources that they need to provide treatment to everyone who needs it. And then just finally, this is one of the most common questions I get, well, why does this vary? And I talked a little bit about that in terms of health service access, but there's also other drivers, and honestly, they're not very complicated. They're the same drivers of health service access across Australia for nearly every health condition that we see. Lower treatment uptake for hepatitis C at a regional level is associated with lower average socioeconomic status. It's associated with the population having a larger Aboriginal and Torres Strait Islander population and the sort of discrimination and access issues that come along with that. And it's also associated with an area having a more remote region and potentially the sort of flow-on issues from that. And it's also associated with having a higher burden of hepatitis C. And so there's all of these kind of structural factors that play into that. And that I think need more investment to be able to be overcome. But one other factor that I wanted to mention in terms of hepatitis C treatment with regards to individual level factors, one of the recent analyses that we've done in Victoria has found that people who were diagnosed with hepatitis C prior to 2010 are much less likely to have been treated. So following up people who've had a historical diagnosis is going to be really important, I think, if we're going to close those gaps. And also we find that people who are currently injecting actually have higher uptake of treatment, which is really incredible to see. But it does mean that people who may be injected historically and haven't been identified as at risk of hep C might be people who are missing out in clinical settings. And so that's, I think, important. And to maybe, I'm not a clinician, but maybe taking a broader approach to screening might be something that could help there. But yeah, it's a complex kind of issue. Okay, so skipping back to hepatitis B briefly. So this is the sort of same sort of framework. It's the cascade of care, but just presented in a different way. And this highlights some of the key gaps for hepatitis B. And so one of the major issues for hepatitis B is that about a quarter of people living with hep B are still undiagnosed. And I'll talk a little bit later about some of the drivers of that with relation to screening. But the biggest gap by far for hepatitis B is people who have been diagnosed but are not engaged in regular monitoring. And so everyone with hepatitis B, it's recommended that they receive at least annual monitoring to check in and make sure that their liver function is okay and that they're not eligible for treatment, or if they're eligible for treatment that they can be engaged in that. But over 3/4 of people who have hepatitis B are not receiving that care. And so that's a really huge barrier. And obviously it means that people can't be engaged in treatment if they're not getting that. And then for treatment uptake, I already mentioned this, and I think Kay covered it as well, but only about half of people who are estimated to require treatment because they're in the stage that would sort of indicate it, are estimated to be receiving it. And so that's a huge gap as well. And that's part of the reason why we've seen that incidence of attributable death from hepatitis B decline, but not go down any further, because those are people who still haven't been treated. And I'll just briefly touch on in the next slide, the sort of similar picture for treatment uptake. So you can see the Murray region there, slightly lower treatment uptake than the national average, but this is very much unsurprising because almost, I think every region, every PHN that's not in Sydney or Melbourne has treatment uptake below the national average. And I think it's important to keep this in context. Half the people in Australia who are not treated for hepatitis B are living in Sydney and Melbourne. So when we're prioritising this issue, it's very important for everyone to get access to treatment, but it's certainly important to keep in mind those broader sort of contexts. But yeah, there is a need for improving treatment access in every primary health network in Australia. And then just briefly dropping into the sort of zoomed in area. And what we actually see is within the Murray region, those key regional cities that I mentioned, or I shouldn't, just the three areas that I talked about, Mildura, Shepparton and Murray River Swan Hill actually have higher treatment uptake than the Murray average, which is really great to see. So just in my last couple of minutes, I want to just talk a little bit about some of the other factors that are playing into these issues. So this is some data from over 450 primary care practices across Victoria. And what we wanted to look at is whether people who have identified risk factors for hepatitis B and hepatitis C, or clinical indications for testing, whether they actually have a record of hepatitis B and C testing. And what we found is that, unfortunately, there's significant gaps. And so you can see that for people with a history of injecting drug use, the uptake is relatively high, and that's really good to see. I think that's quite a well-recognised risk factor. But one of the key issues is with ethnicity. Firstly, over 2/3 of people didn't have an ethnicity recorded in the primary care software. And that's partly due to the sort of IT challenges. It's actually made relatively difficult to do that in a lot of places. But even among those who did have an ethnicity recorded, and it would indicate that they need Hep B testing, less than 1/3 actually had a record of it. And so if we're talking about that diagnosis picture, a big part of that is just this sort of issue of routine screening in this sort of primary care setting. And I'm sure that happens in a lot of other settings as well. But one of the things that was really concerning is a lot of people who have test results that suggest that they have active liver disease, so they have elevated ALT or even an APRI score over 1, which is strongly indicative of cirrhosis in hepatitis B and hepatitis C. Less than half of them actually had a record of a test. And so that's really concerning, that we're seeing people who potentially are at great risk of liver cancer or advanced liver disease who maybe are not being picked up in primary care. So that's something that I think potentially needs to be addressed, and maybe talking about some sort of automated process for that to happen, or clinical audits and that sort of thing. And I think the broader picture that GPs are incredibly overburdened with things that they need to do, and adding this is something that's can cause that sort of prioritization issues and all that sort of stuff. So I think this is just really highlighting that issue of chronic disease management in primary care. It's really, I don't think it's supported well enough at all. But that's opinion, that's not from the data. So. And then just finally, I wanted to talk a little bit about the impacts of COVID. And Kay mentioned this already, and that, decline in screening is really huge, and the decline in treatment uptake that we saw, particularly in Victoria in 2020, obviously, because we had the most pronounced COVID epidemic. So you can see Victoria is that sort of light blue-grey dashed line. You can see that in 2019, we had the highest treatment uptake of any state in Australia. And by 2020, we only had the 5th highest treatment uptake. And so that, I think, is very strongly connected to the disruptions to health services and also the other flow-on effects due to COVID. It's not just as simple as people couldn't go to the doctor. I think people were suffering a lot of psychological impacts, a lot of family struggles, and I think perhaps health issues did not get prioritised, and that's part of that whole picture. But hopefully, now that things are more normalised, we can start to re-engage people into care. And just skipping through the next one, I'll just not touch on that. Yep. And so actually, if we go to the next one, I've got a little arrow on there. Yeah, perfect. And then for hepatitis B, we saw that for the first time ever, the number of people receiving Hep B monitoring declined during 2020. So again, that's really concerning because that level was already far too low. And in fact, we had a decline in the number of people living with hepatitis B because our borders closed and we had no migration essentially for 2 years. And so we should have seen an increase in monitoring uptake, but instead we saw a decrease. And I think that's really concerning. The good news is most people who were on treatment stayed on treatment. So there wasn't a lot of treatment interruption, and that's definitely good. That would have been quite a problem if people weren't coming back for their scripts. And that's something that can happen through telehealth, obviously. So maybe that was more able to be continued. But people getting blood tests, getting their viral load checked, that really dropped off in 2020. And that's obviously a concern given we were already not on track. And then the last couple of slides just highlight this in terms of our trajectory. So I mentioned the national strategy targets. This just gives those in summary, and I've already presented the evidence around the proportion diagnosed in care and receiving treatment. But you can see when we project these based on the current trajectories, we're not estimated to reach our targets until well into the future. So something drastic just needs to change with hepatitis B care. Otherwise, we're going to see considerable numbers of preventable deaths, which would be really unfortunate. And then just finally, I've touched on the hepatitis C trends. We're doing much better with regard to hepatitis C. And based on the trajectory from 2016 and 2017, we were on track, but because things have plateaued, we're actually not on track to meet either of the targets, the national strategy target of 65% uptake or the 80% global target, based on even an optimistic view of the current trends. And so again, we need to see significant changes in what's happening for hepatitis C treatment uptake to meet those. And again, it's not about targets. I don't care whether we technically meet the target based on what's on paper. It's about preventing those attributable deaths. It's about improving people's quality of life. And that's why we have these targets to try and get us there. So that's kind of a whirlwind overview of epidemiology and how we're tracking. So just as sort of a summary, just to emphasize that viral hepatitis is a really significant global health issue and also a local health issue. And the Murray region has a slightly higher burden than some of the other regional parts of Victoria. And so that's something to potentially focus on. And we know that the sort of populations vary according to area. And we have these really effective tools for preventing infection and reducing adverse outcomes. And they have had an impact so far in Australia, but we're not yet on track to meet the targets that would significantly reduce those burdens. And we know that COVID-19 in all its various impacts has had a negative association with those estimates. And I think understanding the priority populations and where the specific gaps are. So for example, understanding that diagnosis or engagement in monitoring is where people are falling out of the cascade, hopefully can help to better target interventions. But I'd be really keen to hear from all of you guys, to hear your experiences and also answer any questions that you might have. So thank you very much.